All right. Thank you, everyone, for coming virtually to our SSAT webinar, Surgical Clinical Trials, Potential Pitfalls and Solutions. On behalf of the Society of the SSAT, I welcome you all. These are some tips for the webinar today. And I think the most important one is that I encourage you to ask the questions using the Q&A feature at the bottom of the screen. We can also bring this live on Twitter. A copy of this webinar will be recorded and it will be on our website at the end of the webinar as well. Brief reminder of our SSAT memberships categories and some of the benefits that you can have. And please register for our virtual annual meeting, May 21st to the 23rd. A brief overview of what we're doing today. We're reviewing 3 different types of surgical trials and trial organizations, evaluating potential methodological challenges that could lead to study failure. And these are from a methodological perspective, which are unique to surgical trials. And to end with a positive note, we want to summarize the lessons that were learned from these trials so that the next ones are better. There are many different types of surgical trials, and surgical trials are thought to be more difficult to perform than medical trials. Surgical trials could be those that investigate different surgical procedures or surgical interventions, and according to the level of difficulty of how can they be performed, we can categorize it in different levels. One of them is studies comparing surgical procedures that differ only slightly. For example, suturing technique, and that's considered to be very easy to enroll patients to. A level 2 studies in the degree of difficulty is studies comparing different ways to perform an operation. For example, a laparoscopic versus an open approach. And level 3, which is more difficult, is a comparison of a medical versus a surgical treatment, such as, for example, PPI versus fundoplication, chemotherapy versus surgical management, so on. In the second type of surgical trials, which is the vast majority of surgical trials, are those that investigate different medical therapies among those patients that are undergoing surgery. And we'll see examples today of both of them. I want to touch briefly about factors that are unique to surgical trials that could affect our enrollment. One of them we would also see today is the timing of the trial in relation to the adoption and the development of the surgical procedures. And this is because many procedures in surgery become standard of care without prior clinical trial evaluation. And therefore, there's no longer an equipoise, and therefore the trials are going to fail. Another key item in surgical trials of surgical interventions is the standardization of the surgical intervention. Surgical trials unique compared to medical trials, we depend on the technical skills of the surgeon and the surgical team. Therefore, we have something that is called learning curve that other trials do not have. So most trials do have a standardization, and there's different ways to obtain that. The lack of standardization would lead to an increased variability of the trial, therefore decreasing our power, and it would be more difficult to enroll. There are some theories that suggest that an expertise-based trials perhaps are easier to perform. Then we go into a little bit more general things. Patient preferences. Patient may have a preference over a surgical type of procedure. For example, if laparoscopic surgery is being performed around in the city, they may already have a preference, and therefore there's no equipoise from the patient's perspective. And there's the surgeon's preferences. There's a lot of research that talks about why are surgeons less motivated to include patients in trials? Are we less tolerant to uncertainty? And understanding that uncertainty is the key principle of any surgical trial. Do surgeons tend to guide our treatment decisions based on non-evidence-based sources like intuition or case series, and of course, funding. We all know that there is less funding for surgical trials. There are other factors that are very common to other types of trials: the study population, the type of the intervention, blinding methods, sample size and feasibility, and informed consent. Today, we're going to start with 3 different speakers that are going to talk about 3 different trials. And then we're going to have a Q&A question session after each presentation. So we invite you to have a discussion about this. Certainly, on behalf of the SSAT Research Committee, our committee chair, Dr. Al-Rafai, and the SSAT, we welcome you all to this webinar presentation today. We will start with Dr. Mary Hahn from Stanford University, who will talk to us about clinical trial in surgery from the VA perspective.
All right. Good afternoon, everybody. Thank you, Dr. Serrano and Ferroni and Berman for putting this session together. I was given the topic of what lessons could we learn from the VA trial of open versus laparoscopic inguinal hernia repair. And I think the unique thing about this trial compared to some of the other trials we're going to hear is it's comparing 2 surgical techniques and some of the challenges that comes with that. So my goal in the next few minutes is just to discuss some of those specific challenges to surgical trials when we're looking at actual surgical procedures, and then some of the benefits and challenges of doing clinical trials in the VA system. So surgical trials, briefly, just to repeat or go over a little bit of what Dr. Serrano already said, is they really pose some unique challenges because you have to define what the gold standard is, and that has to be agreed upon. There really has to be technical fidelity to the trial. So if you're doing a hernia repair, what mesh are you going to use? What suture are you going to use? How are you going to suture it in? And maintaining that fidelity to the trial parameters can be a challenge. We have to standardize the perioperative care. So how are we going to prep the skin? What antibiotics are we going to give? Are we going to place a Foley or not? Any of these other things which may impact some of the complications and outcomes. And we have to ensure that the surgeons that that participate in the trial are actually capable of performing one or the other or both techniques. And there has to be equipoise, meaning that we don't really know what the best outcome will be. So first starts with asking the question and really refining what the hypothesis is. So we want to compare hernia repair. You know, what do we want to compare? What's our outcome? Is it recurrence rate? Recurrence rate at what time? How do we define recurrence? Is it clinical recurrence, radiographic recurrence? And then who decides? Who's the arbitrator of whether or not a recurrence is present? And then do all hernias need to be repaired? Could be another trial similar to the watchful waiting trial. And what's the endpoint of that? How long would you follow those in the watchful waiting arm? Then we get into, if we want to compare types of hernia repair, what hernias do we want to include? What's the technique? What's going to be the gold standard? What's the new technique? And issues unique to surgical trials is really that surgeon experience, that non-conformity, system differences, and then obviously intraoperative events that might require modifying a procedure. So for the VA trial, what they decided on the inclusion criteria was strictly related to men over 18 years of age with an inguinal hernia and a life expectancy greater than 2 years. So this is something that is unique to the VA, very highly comorbid patient population. Exclusion criteria was if it was not a clinically palpable hernia, that patient couldn't be enrolled in the trial. Obviously ASA 4 or 5, contraindications to general anesthesia, presence of bowel obstruction, strangulation, any of those. And recurrent hernia where the prior repair was with mesh was felt to be that we didn't want to enroll those patients in the trial. And then standardization of the intervention. It's important to maintain integrity of the trials and to assure possible differences between treatments won't be missed. And it has to be agreeable by all the key participants in the study. So this, requires a very clear delineation in the operations manual, review of the procedure before each intervention, site visits, video review of surgeons performing procedures. So often before a surgeon can even enroll or a site in a trial, they have to send a video of them performing the operation that is reviewed by the PI or their team. Random or 100% review of the operative reports or videos, trainer review, and then close monitoring of the intervention and outcomes. So how do we figure what those outcome measures are? They could be what we think of more surgeon-centered, morbidity, mortality, survival, in terms of patient outcomes, patient-centered, such as what was the impact on the quality of life, satisfaction, what was the burden on the caregiver for their postoperative recovery, what was their pain postoperatively, and then other indirects such as quality adjusted life year, costs, etc. So what kinds of bias do we deal with when we are doing a clinical surgical trial? The patient decides after randomization that they want to be in the other treatment arm. The investigator captures good risk patients and doesn't offer trial to them. Patients willing to participate in clinical trials are different from the normal population. Motivated patients may or may not be more inclined to participate. Potential sources of bias is subject selection, site selection, investigator selection, outcome measurement. So the inguinal hernia trial was a long time in the planning, and it really wanted to start as a multi-arm study of comparing watchful waiting versus open Lichtenstein repair and a laparoscopic versus open repair. And ultimately, they were split into two separate studies, one funded by the VA, which was the lap versus open repair, and AHRQ funded the watchful waiting trial. The VA has infrastructure actually for clinical trials called VA Cooperative Studies. So they have a coordinating center. You get a statistical team. They help with the data safety monitoring board and all of the oversight requirements that are needed for a clinical trial. The VA Cooperative Studies trial was a 6 million study over 5.5 years, 14 sites, and 2,200 patients were enrolled. You can see the watchful waiting was a $6 million dollar study over 5 years, 5 to 6 sites, and 750 patients. So much more expensive on the outside the VA system. So this is some of the main outcomes of the study, and then we'll get into what some of the issues were with the study. So overall, the laparoscopic repair had a twofold increased risk of recurrence at 2 years. For primary hernias, that risk was almost threefold, and for recurrent hernias, it actually was slightly lower with the laparoscopic repair. They also measured surgeon frustration satisfaction as a predictor of outcome. And surgeons had higher levels of satisfaction and lower levels of frustration with the open repair, meaning that they were more comfortable doing that repair. This again just gets into looking at, did the experience of the surgeon matter? And so when it was primary repair, the gray is a laparoscopic, white is an open. With highly experienced surgeons, there was no difference in outcome. Primary repair with less experienced surgeons, you can see that's where we saw a much higher recurrence rate, 7-fold increased recurrence rate with the laparoscopic repair. And then recurrent hernias with highly experienced surgeons, actually the laparoscopic repair was really dominant in that arm. So what else did we learn? If differences are small, you need a large sample. If the outcome is not death, you have to define it carefully and make sure patients survive to reach the outcome. It's hard to get people who feel good back in for follow-up, and investigators recruiting patients must have clinical equipoise. Surgeons are in general somewhat resistant to standardization. You have to monitor the data throughout the study to make sure there's fidelity to the original study protocol, and monitor the procedures throughout the study. Clinical trials take a long time. Hernia trials nearly 10 years from conception to publication. And thinking about registries and other mechanisms to follow patients beyond the funding period is an important thing to plan for from the get-go. So take-home lessons: policy for centers not meeting enrollment goals need to Also notify the IRB if you go over. So you may have a site super eager participants in it, and then they don't enroll one patient for some reason or another. They can't get the site up off the ground. So you have to be really aggressive and pivot and switch, because your funding will run out before you get your trial going. Watch those important controllable variables closely, regular check-in and follow-up. So VA specific clinical trials, the advantages of it: there's no insurance issues, it's a captive population, central IRB, uniform oversight, regulatory center, and funding is actually available for an RCT. So there is a separate funding mechanism through the Cooperative Studies program. The disadvantage of this, using the VA for clinical trials, is it's primarily a male population who are older and more comorbid, and the technical proficiency of the surgeons varies across centers. So that I will summarize, but the biggest thing is a huge thanks to Lee Neumeier for sharing her slides. This really is her work. She was the PI on this study, and I had the opportunity to work with her on some secondary analyses, and really want to give a huge shout out to her for sharing these slides with us tonight. Thank you.
Thanks so much, Mary. I'm trying to get my video on, but it won't come on. I noted that there's 140 odd people on this webinar. So please type in your questions either in the Q&A box or the chat box, so I can pass those along to Dr. Hahn. Mary, I just wanted to kind of go to your very last slide, and one of the things you said, how were sites recruited for this study, and were there some sites that were excluded? And also, most VAs will have a combination of residents and attending surgeons, and how did you factor in that level of experience in the study design?
So that wasn't in the study design, but it was one of the covariates that was collected, was what was the PGY level of the assistant to the attending surgeon. So I think there's an Association of VA Surgeons organization, which has an annual meeting, and it's a pretty tight network of surgeons who primarily practice in the academic affiliate, VA academic affiliates, and I think it's through that site they looked at volume. So who had the adequate volume to enroll, who had the expertise, and that they had done enough laparoscopic repairs at their site before they could come into the study. So it was looking at factors like that to make sure that they could accrue and meet their enrollment numbers.
A quick question, if you don't mind. So I understand that then there were some videos, and you reviewed as well the operative report. Were there any site visits that would look at the surgeon operating? Is there like a grading score that we would qualify them and things like that?
So my understanding is that there were a few site visits, mostly relied on video, which is harder to do for open operations than it is for laparoscopic operations. So I think that's the advantage of doing a laparoscopic study is the ease of collecting a good video. Yeah.
It's always a question of whether the people that are doing laparoscopic or even the people that are doing open are proficient in what they're doing, and that impacts obviously the results. There's a steep learning curve on those procedures.
Yeah, and I think that clearly showed up in the laparoscopic, and I think in their learning curve analysis, I want to say it was about 75 cases of laparoscopic repairs to when your recurrence rate was equivalent to an open repair. So it's really a long, high learning curve for this procedure.
Mary, we have a question from Ira Leeds. It's actually a very good one for a early career faculty member. Her question is related to putting together a trial in a homogeneous system like the VA. She says, as an early career faculty, what's the best way, even if it takes years, to situate yourself so your idea makes it up the ranks to being considered for funding and approval? I think that not only goes to the VA system, but for any setting in which we conduct a clinical trial. Could you give us your beliefs on that and your mentoring on that?
Yeah, I think, first, I think you have to have a great idea, hypothesis, right? That's going to be relevant for the next 10 years. That won't be, things change so quickly. And then I think for being the PI on it, publishing in that area, so looking at case series, identifying where the gap in the knowledge is, and really making a strong case why a clinical trial needs to be done. And then reaching out to mentors who are thought leaders in that area, and engaging them and helping you kind of make the connections. Where's the best place to do a study like this?
Chris,
Dr. Hahn,
question. Go ahead, Christina. Thank you.
thank you. Dr. Hahn, fantastic talk as always. We wouldn't expect anything less. So I think you touched upon this. In terms of how do you get your colleagues to participate in a trial like this when they might openly say they're enthusiastic about it, but then they don't accrue patients, or if they're somewhat critical of the trial and may not be in agreement? How did you manage that and get your colleagues to enroll in this trial?
Yeah, so I think that some of the key things are, that are good about the VA is that, people aren't usually like on an RVU, they're salaried. And so if they, it takes a little longer to see patients in clinic or enroll them. But the biggest thing is they got a research coordinator for the trial who also could potentially help them out with other research projects. And I think that in the VA system, where it's harder to get some of those things in the budget, I think that was a big bonus for recruiting surgeons into the trial. And I think people were really interested in answering the question. It's a really common operation in the VA. I think there was some equipoise and really wanting to be the organization that, tried to answer the question.
And one last question before we move on from our next speaker is what factors were taken into consideration in regards to standardization of surgical techniques, sutures, mesh, types of mesh, et cetera, when you conducted or put the study together, Mary?
Yeah, so all of that was standard, standard. They did have the choice for open repairs to do regional versus general anesthesia. So they did allow for some of that, and they collected which type of anesthetic was used. But down to the skin prep, how the hair, was it removed by clipper, razor, what type of skin prep to use, what antibiotic to give, with and without allergies. So all of that was pretty standardized, suture, mesh product all along.
Super. Thanks so much, Mary. Really appreciate the wisdom and the perspective on that. Great stuff.
Thank you.
I'd like to move on to our next speaker, who is Vikram Kate from India. I'm privileged to serve on the research committee with Vikram, and he's been a great insight and has added a lot to our committee in that regard. I think it's also super to have him on because we have insight from a completely different international country and how trials might be conducted a little bit differently than they are here in the United States. And he's going to speak to us about adapted ERAS pathway versus standard care in patients undergoing emergency small bowel surgery. Vikram, thanks so much for your insight.
Thank you very much. Thanks a lot. At the outset, I'd like to thank the SSAT and the research committee for giving me this opportunity to share some of our experience on this trial. I'll be speaking about our experience on this particular single center investigator-initiated trial on adapted ERAS pathway versus standard care in patients undergoing emergency small bowel surgery. Now, this will focus on these three areas. As I mentioned, it's an investigator-initiated single-center trial. It was carried out in an emergency setting, and it was also carried out in an area. It's relatively new, although enhanced recovery after surgery is a established procedure, but still in the emergency setting, it is not yet established. So as I mentioned earlier, that almost two and a half decades, late 90s, the concept of ERAS has come. But when it comes to emergency, there are many challenges in implementation, especially the preoperative component. So still, this procedure is not yet initiated much. And these are the few earlier trials, what we have seen, what you've come across, the emergency laparoscopic repair. This was published in 2014. and the other one on urgent colectomy. These are the earlier trials which have come on emergency ERAS, and we followed it up with our own trial in 2017 on patients with perforated duodenal ulcers. So although I'm talking about one trial today, but actually it will be a combination of experience on 3 trials. Now, this is the first trial we started and finished, completed and published in 2018. This was on adapted ERAS pathway versus standard care in perforated duodenal ulcer. This was followed by the present trial, what I'm going to speak today, on small bowel surgery. And this is the third trial which we are going to present next month in the SSAT conference. And this is on actually perforation peritonitis. Now, most of these studies, as I said, they were one of the earliest on these aspects of emergency ERAS. So planning and execution became a challenge because the standard guidelines, other publications and all, they were not available when we actually started our first trial in almost 2015. So for this present trial on emergency small bowel surgery, whether it can be implemented with the help of the adapted ERAS pathway, we had these 3 primary research questions. First one, is it safe and feasible? Because it was an emergency setting, not being carried out very often. Then does the application of ERAS pathway lead to the length of reduction in the length of hospitalization? And if we use this ERAS pathway in an emergency setting for this particular procedure in this particular trial, we thought whether it leads to any rise in complications. So our primary objective we kept as length of hospitalization, whether the reduction is there in emergency ERAS, and these were the secondary objectives. Time elapsed until resumption of oral feeding, need for nasogastric tube reinsertion, whether we need any extra analgesics, and how are the readmission rates, reoperation rates, and if it leads to any complications such as superficial and deep space SSIs, surgical site infections, post-operative ileus, pulmonary complications, or urinary tract infections. In our first trial, where we wanted to do what I mentioned on perforated duodenal ulcer, actually we wanted to, we were not very sure whether we should do a non-infuriated trial, compare the complications, or we do a supurated trial and do length of hospitalization. But one of the primary goals and aims of ERAS is to reduce the hospital stay. So we thought we'll do it as a supurated trial and chose the length of hospitalization as the primary outcome. So this was carried out in the Department of Surgery, Jawaharlal Institute, JIPMER, from which I belong to. And then this was an investigator-initiated single center prospective open label parallel arm supurative randomized controlled trial. Patients above 18 years who were diagnosed in emergency to have small bowel disorders leading to surgical emergency and who planned for emergency laparotomy were included and allocated into the 2 groups. Because it was, again, as I said, in the earlier phase, so even for most of these 3 trials, what we have actually done is we have included only ASA class 1 and 2 patients. Some of our exclusion criteria: irreversible septic shock, polytrauma patients can get as a confounding factor, pregnant patients, and if the duration of symptoms is more than 5 days, sometimes you get patients like that. So we thought we'll exclude that in this particular trial. So randomized into 1:1 ratio, and group 1 was standard care group, which received the standard perioperative care as per the department protocol. And group 2 was ERAS group, which received the perioperative care according to the adapted ERAS protocol. Now at this stage, few challenges and emergencies we faced. One was to explain the study and obtaining consents from the sick patients when they come to emergency medical services. Then to explain this again to the caretakers pre-admission. Then excluding moribund patients, because as I said, in the initial phase, we didn't want to include, we wanted to include only SA1 and 2. So that became a limitation, whether it can be extrapolated to the other types of patients. Then securing epidural catheter emergency, as it was the carrier on emergency, most of the times from the anesthesia teams also we used to have resident level people. So they had difficulty in securing the epidural catheter. So it was not achieved in all the patients. And because we had done a prior trial and this was the second in this series, it was the protocol was more standardized and it became better. And of course, when in the earlier study, we had included only duodenal ulcer perforation patients, but this we included all small bowel pathologies. But fortunately, those things got balanced during randomization because different types of pathologies were included. Overall sample size, we took about 80 for this thing, including the attrition rates, etc., for a reduction of less than 2 days of length of hospitalization. Now, this was the preoperative component: patient education, non-opioid multimodal analgesia, interjugular vein cannulation was done. Intraoperatively, standard anesthetic techniques were used. Use of morphine, other opioids were excluded as far as possible. Sometimes when required, short-acting opioids and anesthetic agents were used, and epidural lidocaine in patients who had epidural catheter. In the post-operative phase, again, we used non-opioid multimodal analgesia, metoclopramide, and antibiotics were used for 5 days, standard antibiotics what we use. The drains were removed irrespective of resumptions of oral feed, less than 100 ml was there, and nasogastric tube also was removed when it was less than 300 ml. And the patients were started on orals once there was first appearance of bowel sounds. And then the moment we started them on unrestricted volume of liquid diet, and then it was switched over to the normal diet in the next 24 hours. So this was the protocol we followed in the adapted ERAS protocol, and this was the post-operative care. All the analgesics what we used were non-opioid analgesics on different days. In the conventional arm, this was the thing, drains were actually removed when that is the usual policy in the standard of care that time you're following, that for if the patients were put on liquid diet for more than 24 hours, and nasogastric tube less than 100 ml. These were the challenges again, as one of the questions asked in the earlier talk, that we find some resistance is always there in these sort of trials. Initial phase hesitancy is there to remove the nasogastric tube earlier than what the practice, removing drains, moving the patients on post-op day 0, pain control with the help of only NSAID when we are not using opiates on the adapted ERAS group. And then goal-directed fluid therapy is one of the established protocols of ERAS. So this also, due to some logistic problems, we could not use, and we had to use the CV monitoring for the fluids. This was intolerance to diet. This was how it was defined. And then once the patient tolerated, we again resumed them on the diet. Discharge criteria was tolerated solid diets for 24 hours, and then if that passed stools. And follow-up we did at 10 days and then at 30 days. And for any need of complications, readmissions, reoperations, all those things were determined. This is we included assessed for eligibility 106 patients, 24 were excluded for variable reasons, and then randomized 82, and we can see that 40 in this standard care and 42 in the ERAS arm. Some were excluded due perforation and then ileocolic anastomosis and then appendicular perforation. So 35 were actually allotted to each arm. And then there was no loss to follow-up. This is one of the advantages of short follow-up. And then that's what was there. This was the primary outcome. Length of hospitalization, we found almost a reduction in 3 days between the ERAS arm and the standard care. And we can see here the length of less than 7 days, almost 10 of the patients were sent home earlier in the adapted ERAS arm. These were other results. Mean day of withdrawal of nasogastric tube, time to first flatus, time to first stool, mean fluid diet, starting solid diet, all these things were earlier, significantly earlier in patients with ERAS and standard care compared to standard care. Complications also were comparable between the two groups. Although there was a trend that on the adapted ERAS group, the complications were lower, but we did not achieve any statistical significance. But definitely there was no rise in complications in the adapted ERAS group. So these are the few strengths and limitations of studies. It was novel area. This is one of the earliest studies on emergency ERAS for small bowel perforations, had adequate sample size. We could include maximum number of possible care elements. These are the limitations. You see, this is the usual standard, the hospitalization setup, 8 to 10 days. Minimally invasive approach, again, due to logistic reasons, could not be used in emergency. Cost analysis, again, could not be achieved because public care hospital, most of the patients actually are treated almost free of cost. And then uniform epidural analgesia, as I said, difficulties were there, and that's why we could not use neither goal-directed fluid therapy. These are the usual barriers of ERAS, elective ERAS also, surgeon barriers, family barriers, healthcare team, and patient barriers. So in emergency setting, these were the barriers we particularly found. That complex nature of IRAS protocol has led to poor adherence. Post-discharge functional recovery, sometimes they go back home also and they might not continue and start the work, because one of the problems what we had was that the patients, most of the patients belong to lower socioeconomic strata. So these are lessons we learned from this particular trial and the other trials. In centers with good patient load, an investigator-initiated single trial is possible, can be completed within a relatively short time. We took almost 1.5 hours to complete it. Emergency setting studies may need multi-step and multidisciplinary involvement in a short period of time. So that can be sometimes a challenge. In novel study areas like this, still the management guidelines are established. A single study may be more convenient than multiple multi-centric trial, because to convince everybody may be slightly difficult. And because we had a previous experience of one trial, the methodology was fairly standardized. It became a little better, and shorter follow-up led to a better compliance. These are the other lessons. What we learned was prior experience in emergency setting. As I mentioned, it was definitely better in this trial compared to implementation than the earlier one. Minimal access, that's what I said, is a problem, that is a limitation. But in spite of that, even if it was not available in emergency setting, we could carry out this trial quite comfortably in the open surgery mode. And this, again, awareness and training of IRAS guidelines of surgeons and so everybody is on board, it becomes very useful. And if you have a good communication team leader, definitely it can be a very successful trial. So again, I'd like to thank the SSAT Research Committee of the SSAT, particularly the chair, Dr. Wadda, and my colleagues, Dr. Pankaj Kudra, who's a professor of anesthesia. Very important collaboration from the Department of Anesthesia is required for IRAS. My colleague in the Department of Surgery, Dr. Suresh Kumar, my colleague, Dr. Mahalakshmi, Associate Professor of Preventive and Social Medicine, and of course, my surgical trainees who carried out the trials. The first one was carried out by Dr. Mohsina. The second one, which I am presenting, is carried out by Saurabh. The third one, which I'm going to present next month, will be carried by Pranavi and Dr. Guru Shankari Balakrishnan, who overall coordinate with me for everything and help me in making this slides, presentation, and everything about IRAS. Thank you very much for your kind attention.
Thank you very much, Dr. K. I think this is certainly very interesting. We do have only 2 minutes, so I'm gonna hope I can ask you a few questions before our next speaker. So you ended up randomizing 82 patients. I wonder, and I want to compare your research process to ours in North America. How much money did you need in order to randomize these 82 patients and follow up?
Actually, as I said, basically there's a public care hospital, public sector hospital, and we are treating the patients free of cost. And as such, we did not have any funding for this trial. This was all hospital-based trial, so it was not required at all. And
I wonder if there's any funding opportunities within the India in order to do trials like this. And I wonder about collaborative studies between the US, say, India as well.
We have fundings because this is a tertiary care all India institute where I'm working. So we have funding for the trainees as well when they actually put up their projects for their postgraduate dissertations. We have that training, that is an intramural grant, what we call. And definitely when we require funding, we have national agencies in India which can fund the different trials. So that usually is at the level of faculty, they have to apply for that and then they get the funding for that.
Right. Thank you. Thank you very much. So it's 8:09 and Christina, I'm going to leave this to you now.
Thank you, Dr. Serrano. Well, it is my great honor to introduce Dr. Yun-Shin Chun. She and I have been great friends for a very long time. After training at Mayo Clinic, she did her fellowship at MD Anderson. And we're all looking forward to her talk on the lessons learned from the randomized controlled trial of postoperative thoracic epidural analgesia versus intravenous patient-controlled analgesia after major hepatopancreaticobiliary surgery. So Dr. Chun, we're looking forward to your talk. Thank you.
Thank you for the privilege of participating in this webinar. So my goals are to review the experience with collaborative surgical clinical trials with other services, in particular anesthesia, and to discuss areas of success and pitfalls of performing institutional collaborative trials with other disciplines. What motivated us to conduct this trial? At MD Anderson, we have a sky bridge that connects our outpatient and inpatient buildings, and this sky bridge is 1/4 mile long. If you see a patient walking on this sky bridge on postoperative day 1 after a Whipple, she probably had an epidural. However, there are controversies about the use of epidural after major HPB surgery, in particular postoperative hypotension. Our primary endpoint was to compare postoperative pain control and quality of life between epidural and IV PCA among patients undergoing liver or pancreatic resection. Our secondary outcomes were to compare postoperative surgical outcomes and immunological responses, such as natural killer cell activity and cytokine levels. With this lofty goal of achieving near zero pain in patients with big abdominal incisions, we embarked on this clinical trial in 2011, and we encountered several obstacles. These pitfalls included departures of key people, lack of access to research infrastructure, epidural complications, mid-trial protocol changes and administrative hurdles, and the trial needed 5 years to complete. A surgical oncology fellow wrote the protocol and worked out many of the administrative kinks and then graduated. This left a void that needed to be filled by the principal investigator, research nurses, and incoming fellows. We had a high turnover of research nurses and coordinators. In addition, data was recorded by different departments on separate Excel sheets. Surgical oncology logged perioperative data. The anesthesia research team recorded pain and quality of life scores. And a separate translational research team recorded natural killer cell activity and cytokine levels. The lesson we learned was we were fortunate to have a consistent statistician and surgical oncology research manager over the study period. In the future, for clinical trials, we will store data in REDCap instead of Excel and maintain research infrastructure that keeps detailed chronological records. This is much more efficient than searching your inbox for an email sent by a data coordinator many years ago. Another pitfall was lack of access to research infrastructure by some members of the team. Patients were randomized the day of surgery by anesthesiologists who submitted a request to a web-based research system. In the course of the trial, we learned that several anesthesiologists did not have access to the research system to randomize, and this resulted in OR delays. The lesson learned was to form a critical mass of providers familiar with the protocol and research infrastructure. Another pitfall was epidural complications. The randomization was skewed 2.5 to 1, epidural versus PCA. This was designed to capture more epidural failures and complications. The most common complication of epidural was hypotension occurring in 14% of patients. In some patients, hypotension was inappropriately managed with fluid boluses and not holding the epidural. The epidural catheter migrated or malfunctioned in 2 patients. Lesson learned was again to form a critical mass of providers familiar with the protocol. We educated anesthesiologists, the postoperative pain team, PACU nurses, and surgical oncology fellows to securely tape the epidurals and check placement frequently. They were also educated to hold the epidural as the first intervention for hypotension. The initial protocol was designed for 120 evaluable patients. In the course of the trial, most of the patients had undergone liver resection. We submitted an IRB amendment to increase accrual to 140 evaluable patients because we wanted to capture more patients undergoing major hepatectomy, because these patients are more likely to have postoperative complications. We waited 6 months before the amendment was approved. And this was partly because of a barrier in communicating and understanding the significance of major versus minor hepatectomy to our IRB reviewer, who was a non-clinician. So the lesson we learned was that for any protocol change, involve your statistician early. The statisticians are often more familiar with IRB contingencies and regulatory procedures. Lastly, the protocol required 5 years to complete. It is important to have 1 to 2 faculty champions to keep the motivation going. So constantly motivate the team. Be simple, ask one main question with the randomized trial. An unknown with any clinical trial is patients' willingness to participate. It is important for the faculty to discuss the trial with each patient and convince the patient of clinical trial benefits. For this trial, benefits included a dedicated liver anesthesiologist and enhanced patient care. Despite faculty engagement with the patient, we had several incomplete pain and quality of life surveys because patients were too tired, sick, or refused. Despite these pitfalls, we had successes, especially our partnership with the anesthesiology department, who funded 50% of our research nurse salary. Through the course of this trial, we formed a critical mass of dedicated liver anesthesiologists and CRNAs. We met our primary endpoint. Patients who underwent epidural had lower pain scores and less narcotic use without increased length of stay or complications. Because of the results of this trial, in this recent study of over 900 operations at MD Anderson, patients undergoing liver resection had the lowest median total inpatient opioid use. In conclusion, as you're going through a clinical trial, if you feel like this mountain climber with no end in sight, you may need ibuprofen. Give yourself time. When faced with a regulatory challenge, you can table it and come back to it another day. And most importantly, ask for help. Thank you.
Dr. Chun, that was a fantastic talk, and congratulations on the trial. Obviously, very important information. So I guess I would ask you the same question I asked to Dr. Hahn. When you have colleagues who are skeptical about the trial and in their mind have already made up their mind so that they've lost equipoise, how do you convince them to participate and enroll their patients? Because we all know as soon as we start enrolling patients in clinical trials, it's a lot more work for the person who is talking to the patient, and obviously a little bit more cumbersome when in clinic.
So one, for this trial, we had a handful of surgeons who really pushed the trial. And so, as I said, it's really important to have 1 to 2 champions. And then to have your research nurses screen the clinics and then sort of bug people and remind them about the clinical trial.
Well, that sounds like good infrastructure and definitely quite a bit of help to get the trial underway. If you had to choose one lesson or the most important lesson that you learned running this trial, what would it be for our audience?
The statistician was so key, because with people leaving and then having the data in sort of separate departments, having that consistent statistician to finally look at the data was really, really important.
If I can just step in, I think this is great, Dr. Chan, involving the anesthesiologist in a study such as this one. I think the collaborative effort has to be certainly blows my mind. I think it's very difficult to do research with surgeons, and then if we add the anesthesiologist to the equation, I think it just becomes more difficult. In this study, who was doing the consent for the patient? Who was introducing this study to the patient?
So the surgeon would talk to the patient about the trial in clinic, and then we would have a research nurse or data coordinator do the actual consent. Right.
And then the anesthesiologists were in charge of doing the randomization the day of the procedure?
That's correct. Mm-hmm.
Would you say that it might be easier if the randomization would occur differently, or what were the reasonings for doing the randomization the day of? I mean, certainly you want to do it as soon as the intervention happens, but I'm afraid that it would lead to those delays in the operating room time, which in my hospital would be would be something not acceptable.
Well, so after the consent, a number of steps have to occur. We have to clear it with our financial team, make sure their insurance will approve. Then we have to run them through our research registration systems. So a number of steps had to happen before we could randomize.
I understand that. How about a collaboration with other institutions? Do you think this is something feasible in this type of trials?
So the way we do the epidural, it was very specific, and again, we had to get our anesthesiologists who are really, really good at placing them. And so I think to do that with another institution, we would have to have that same quality assurance and have that consistency. But yes, definitely feasible.
So Dr. Chan, now that you've completed this trial, does everyone get an epidural?
So this trial started in 2011, before the advent of tap locks. So even though it was published not that long ago, now we have a new trial comparing tap locks and epidural.
That's great, congratulations. I'm hoping that someone from the audience might have a question for Dr. Chan. I don't know if any of the other panelists maybe have another question for Dr. Chan.
I'm happy to chime in. So I just want to congratulate you on this study. And I think it really, there's a lot of lessons to be learned about how, advances change over the course of a trial. It takes so long to do a trial and to get the data and publish it. But I still think it's really an important finding. So I just want to congratulate you on doing the trial, getting it published and presenting here today. I guess, how do patients feel about this? Did you have trouble enrolling patients in terms of the equipoise?
There were a couple patients who just didn't want an epidural, but most patients, again, it was really important for the faculty member to talk to the patient about the trial and the benefits. And so most people did agree.
I think that's a very good question. Sometimes there is equipoise among surgeons, but then patients already have a preference of what they want to do. And I wonder in this new trial of the tap locks versus the epidural, whether patients would have a preference of one or the other, right? As one is much less invasive.
Right. So the current trial is ongoing, and I'm not quite sure how that's going to play out. in terms of
It's like-
equipoise.
Might be important, or even the other panelists. Even the other panels, do you think it might be important before starting the trial? I know when we're doing grants, we have to check that we have talked to patient representatives, and how do we do that? Like, how do we know what patients thinks, and how important is that when starting up a trial?
Well, I'd actually like to ask that to Christina, in maybe your alliance trial, looking at upfront neoadjuvant chemotherapy versus upfront surgery for resectable pancreas cancer. That's a lot of our patients come to us with preconceived notions. They either want surgery, they want chemotherapy, but and a lot of us have gone to using neoadjuvant therapy for every pancreas cancer patient. So maybe you could help answer Pablo's question.
Yeah, Steve, thank you very much. I think that that's a great question, and that has been definitely an issue for this alliance trial. But I think we all need to remember that there is currently no phase 3, trial that can support neoadjuvant therapy in the resectable patient, and we don't want to make the same mistakes that we made in colon cancer. And so, what I usually tell the patients is the standard of care is an operation followed by adjuvant therapy, but that you would get the exact same treatment. And the question is whether getting it up front and getting some of your chemotherapy up front will not only be easier on you as a patient, but also could potentially be a better way to treat the pancreatic cancer. And I think usually after about a 5-minute discussion, explaining some of the pros and cons, most of the patients that even come in with a preconceived notion of what they want have been agreeable to enrolling into the trial.
And
My impression is probably for something about TAP versus epidural. I mean, that's not what they're coming for. And so I think that they would trust their surgeon to say, this is an important question to answer. We want to control your pain, and we just are looking at the different alternatives of the best way. So hopefully patients would have less of an opinion, about which way they wanted to go.
Yeah, great.
I just want to follow. There's a question from the audience, but I just want to follow very quickly on this, Dr. Perroni. When this is very important, the way that the surgeon introduces the study to the patient, I think it's 90% of the response that you're going to get. Certainly, you need an interested surgeon. Do you think there is a role in writing in the protocol the way or the recommended way that we should talk to our patients introducing the trial? Like the way that you explained that to me, I think it's unique. I think it's great. I think I should use that to introduce the trial to my patients. But then if it is not written in the protocol, I would not know that.
Yeah, no, I think you bring up a good point. We've had a few webinars that were organized by the Alliance to try to assist with some of the wording of the presentation, not only for the physicians, but also for the clinical research assistants. But I think that that's a great idea, because that may help set a better framework or a more consistent framework as to how it is introduced to our patients.
There's a question from the audience asking, here in Canada, we surgeons do not really explain the study to the patient, but we say, can a research coordinator talk to you? And if they say yes, the research coordinator will talk. So the question says, does the IRB has any concerns about surgeons approaching their patients about research participation because of the nature of the surgeon-patient relationship and concerns about coercion?
I should say our IRB did not have any concerns regarding that.
Yeah. There's a very important question about funding. Yes. I don't know if somebody wants to talk about funding and technique, surgical trials, talking about technical trials. I think perhaps Dr. Mary Hahn has some thoughts on that.
Yeah, I think, the challenges are there isn't like an institute that really is, saying this is, our sweet spot, what we're going to fund. So I think that's where surgeons usually struggle. And I think the VA can be and has done a lot of really important trials in vascular surgery, as well as some general surgical issues. The NCI has funded, like the lap open colon resection for colorectal cancer trials. So it's a uphill battle because they're really expensive. And I think that's where you really just have to make the case that there is an important knowledge gap that the trial will answer, and that things won't change so much that that question will be irrelevant by the time you finish the trial.
With this, we made it to 8:30, and I don't want to keep anybody else beyond our allotted time. And I really, really thank everyone who participated today, Dr. Hahn, Dr. Ferroni, Dr. Chan, Dr. Kate, and Stephen, and everybody who is behind this. Thank you so much, and I hope to see you guys soon. Bye then.
Thank you.
Thank you.
Thank you.
Great,
Thank you.
thanks for
Thank you.
organizing.
Thank you. Thank you.